Now next we will be discussing skin lesions. Okay, now later on we will be discussing various skin conditions, and in these various skin conditions various skin lesions are seen. Okay, now if you can identify the skin lesions, their distribution, their arrangement, then the diagnosis of that conditions become very simple. Okay, so skin lesions are very important and the primary aspect of any skin examination, and you should remember them and you should be able to identify them. Okay, so we'll be discussing various skin lesions. Like here you can see these are two patients. The skin lesion in both these patients have one similar feature, and that is the lesions are neither raised nor depressed. Okay, so the lesions are neither raised nor depressed. They are just at the level of skin. They are not raised, they are not depressed. The only thing is color change. Okay, so if the lesion is neither raised nor depressed, that is if the lesions are flat, look at the size. If the size of the lesion is less than 0.5 centimeter, we call them macules. And if they are neither raised nor depressed, that is flat lesions and more than 0.5 centimeter in size, then we call them patch. Okay, so here you can see very small lesions. They are dark in color, and here you can see slightly larger lesions. They are light in color. So if you measure them, and if they are very small, less than 0.5 centimeter, you can label them as macules, and if they are large, you can label them as patch. Now in some books and guides you will find instead of 0.5 it is written less than 1 centimeter, and in patch it is written more than 1 centimeter. Okay, so this difference is due to difference in American and European standards, but whatever it is, you just remember that if it is small it is a macule, if it is large it is patch. So we are discussing primary skin lesions. So the first primary skin lesion is macule and the second primary lesion is patch. So here again you can see the same diagrammatic representation. Both are similar. The only difference is size. If the size is small, less than 0.5 or 1 centimeter, we call it macule. If the size is more, that is more than 0.5 or 1 centimeter, we call it patch. Now in this lesion you can see that it is not flat. It is raised lesion. Okay, so when the lesions are raised, and second thing is, this raised lesion is not due to some pus, formation of pus or due to fluid. It is a solid lesion. Okay, so if it is a solid and raised lesion and it is small, that is less than 0.5 centimeter in size, and if it is large, that is more than 0.5 centimeter in size, we call it papule and nodule. So here you can see these are very small raised solid lesions. So if you palpate them, you can feel them. Okay, so in macule and patch there is no role of palpation because there is only color change, there is no texture change. They are not raised or depressed lesions, but here they are raised lesion and they are solid. So if you palpate them, they are solid and raised. You can easily palpate them and just measure the size. If the size is small, we call it papule, and if they are large, we call them nodule. Like this is a large, more than 0.5 centimeter, it is a nodule, while these small lesions which are raised, these are papules. Now in nodule, I told you that these are solid and raised lesions. Okay, so solid, raised lesion. Okay, so let us consider this is a nodule. This is a solid and raised lesion. Okay, now here this patient is having plaques. These are also solid and raised. What is the difference? The difference is that in a nodule, which we have already discussed, in a nodule this vertical diameter is more than the horizontal diameter, while here this lesion is slightly flat and horizontally it is more, vertically it is less. So this is a plaque. So if the solid raised lesion is horizontally more, it is raised, it is solid, but it is horizontally more, we call it plaque, but if it is vertically more, we call it nodules. Okay, so this is a nodule because it is vertically more, while here this is a plaque because this is horizontally more. So all these are plaques, they are horizontally more and they are raised lesions. So these are the plaques of psoriasis. You can see scaling also over them. But if the lesion is pus filled, so any lesion which is pus filled, we call them pustules. So these are pustules. If they become very large, we can call them abscess also, but if they are small and they are simply pus filled, all these are pustules. Then if the lesion is fluid filled, okay, so it is not solid, it is fluid filled raised lesion, then again you can see the size. If it is less than 0.5 centimeter in size, we call them vesicles, and if they are more than 0.5 centimeter in size, we call them bulla. So when the lesions are fluid filled and small, these are vesicles, and if it is a very large, more than 0.5 centimeter, it is bulla. Here you can see, you can just by looking at the lesion, you can identify that here the fluid is clear fluid, while here the fluid is having little bit of blood, it is hemorrhagic fluid. So this is hemorrhagic fluid filled bulla and this is clear fluid filled vesicles. Okay, so the primary skin lesion here are vesicles and bulla. If the lesions are transient, what is the meaning of this term transient? Transient means for a very short duration. Okay, so transient lesions are seen in urticaria. This is a patient suffering from urticaria, where transient, that is the lesions last for less than 24 hours. These are known as wheals. Okay, so wheals are seen in urticaria. These wheals, as I told you, in urticaria the hyperactivity of the mast cells is there. So due to various triggering factor, what happens, the release of histamine occurs and that portion becomes erythematous and raised. So these erythematous raised lesions which are seen, but they are transient lesions, they last for a very short duration. Okay, so these transient erythematous lesions which develop in urticaria, these are known as wheals. Okay, these wheals are generally due to accumulation of fluid. There is increased permeability of the blood vessels and the fluid accumulates, and this accumulation occurs in dermis, superficial. But if the same thing occurs in subcutaneous layer, that is accumulation of fluid in the subcutaneous layer, what happens, the swelling is more severe and this leads to angioedema. Angioedema is not transient, it is persistent, and generally it stays for more than 24 hours. Okay, so if these are transient erythematous lesions or transient wheals, this is seen in urticaria. This is due to accumulation of fluid in the dermis, while these are persistent lesions more than 24 hours, they are due to accumulation of fluid in the subcutaneous layer. This is angioedema, like you can see this swelling, this is due to angioedema. Okay, now sometimes there is extravasation of the blood. These lesions are formed due to extravasation of blood. That is, the blood have come out of the capillaries and accumulated beneath the skin. Now this can be of three types. It can be purpura, it can be ecchymosis, or it can be petechiae. Depending on the size, if they are very small, like these very small lesions 1 to 2 mm, these are petechiae. If they are more than 10 mm, this is ecchymosis, and if it is in between 3 to 9, then it is purpura, more than equal to 10 mm. Okay, so depending on the size, due to extravasation of the blood, petechiae, purpura or ecchymosis might be formed. If it is 1 to 2 mm, it is petechiae. If it is 3 to 9 mm, it is purpura, and if it is more than equal to 10 mm, then it is ecchymosis. Then there is one investigation I told you, that is diascopy. So diascopy is a very important investigation where you press the skin with a glass slide and you can differentiate various lesions. Okay, so just now I showed you purpura. So purpura can also be differentiated from other rashes, like in viral conditions rashes might develop, and many a times these rashes might look like purpura. Okay, so whether they are purpuric rashes or they are non-purpuric rashes, how to identify them? Simply do diascopy. So purpura is extravasation of the blood is outside the capillary. If you press it, it is not going to blanch. So purpura on diascopy do not blanch, while viral rashes, erythematous rashes or hemangioma blanches. Okay, so this diascopy is very important to differentiate whether it is purpura, purpuric rash or non-purpuric rash. Then we are going to discuss secondary skin lesions. Secondary skin lesions means that if there was a primary lesion and any change which occur over the primary lesion is known as a secondary lesion. Like if a patient was having a bulla and this bulla ruptured, and when it ruptured, the exudate, the fluid which was coming out forms the crust, then that crust becomes a secondary lesion. Okay, so we are going to discuss the secondary lesion. Like you can see here, the patient is having a lot of crusting over the face. Okay, so this crusting is a secondary lesion. So crust is a secondary lesion, and if you look at the color of the crust, this is very characteristic. It is golden yellow crusting. So this golden yellow crusting we will be discussing later in bacterial infection is feature of non-bullous impetigo. So this is the characteristic crusting, golden yellow crusting, which is seen in non-bullous type of impetigo. Crust is a secondary lesion. Similarly, fissure. So if there is a breach in the skin, or if there is a crack, that fissure is also a secondary lesion. Similarly, lichenification. I already told you lichenification while we were discussing chronic eczema. That is, lichenification is characterized by three things: HMP, skin hypertrophy, increased surface markings, and pigmentary changes. So if you look at this lesion, see, this is the surrounding normal skin and this is the lesion. So in comparison to this normal skin, this is the surrounding normal skin. In comparison to this normal skin, if you compare here, you can see that the skin is appearing slightly thickened. Okay, if you palpate also, you will find in comparison to normal skin, this is thickened. So there is hypertrophy. Then if you look at these markings, the skin markings are present here also, but they are very prominent here. Okay, so they are very prominent. So increased surface markings, and in comparison to this normal skin, the color is also dark. So color is also dark. So this is pigmentary changes. So all these three are present here. So these are what? These are lichenified lesions. Whenever we discuss about lichenification, there is one more lesion which we should discuss, and that is poikiloderma. Poikiloderma is characterized by atrophy. So instead of hypertrophy, there is atrophy. Telangiectasia. Telangiectasia means that increased superficial dilated blood vessels. Okay, so there are superficial dilated blood vessels and pigmentary changes. So if you find these three things, then we call it poikiloderma. Poikiloderma. Okay, this can also be very easily remembered with this mnemonic, that is ATP. So if it is ATP, it is poikiloderma. If it is HMP, it is lichenification. Okay. Then milia. Milia are small keratin cysts which are formed. Sometimes they might be formed due to some primary lesion like bullous pemphigoid. When the lesions of bullous pemphigoid heal, they might leave behind milia. And sometimes they might develop de novo, that is without any primary lesion. They might develop like these lesions which develop over face. So milia are small keratin cysts which may develop where the lesions of bullous pemphigoid heal, or they might develop de novo over face. Okay, so these small keratin cysts, these are milia. Then scaling, these are also secondary lesion. Scaling, so small fine scales might be present. Like you can see, this is a psoriatic lesion which is erythematous plaque and it is having silvery white scaling. So scaling is also a secondary lesion. So in psoriasis, silvery white scaling is present and the lesion are erythematous plaques. Okay, so that plaque is a primary lesion. Okay, and the scaling which occur over the plaque, that is the change over the primary lesion, is the secondary lesion. Okay, so in psoriasis, erythematous plaque with silvery white scaling is seen. Plaque is primary lesion, scaling is secondary lesion. Then there are few spatial lesions, like this is a spatial lesion. As you can see, this is a lesion which is appearing something like this. Okay, this is what? This is burrow seen in scabies. They are formed in stratum corneum. So in the superficial dead layer, what happens? This mite which causes scabies, that is Sarcoptes mite, it drills a burrow, and this burrow is generally serpentinous. Serpentinous means S-shaped, like a serpent, like a snake. Okay, so this generally is S or serpentinous or linear shaped lesion. This is burrow. So burrow is a spatial lesion. Why this is spatial? Because if burrows are seen, it is very characteristic of scabies. Okay, so this is a spatial lesion of scabies. Similarly, comedons. Later in acne, we'll be discussing comedons. Comedons are the most characteristic lesions of acne. Okay, so these small raised lesions, you can see these are all comedons. Okay, so these are acne lesions, but when they are large, like this one, this is a papule. Papule, I already told you, papule are solid raised lesions less than 0.5 centimeter in size. Then scleroderma. Scleroderma. Okay, so in these patients who are suffering from scleroderma, there is bounding of the skin. Skin is so tightened and it appears as if it is bounded. So if you try to lift the skin, normally our skin gets lifted, but here it is bound, teeth down. So if you see such bound skin or sclerosed skin, that is seen in scleroderma, and such sclerosed skin which occurs due to bounding of the skin is again a spatial lesion. Then you might find various types of scales, and depending on the type of scale you can identify the condition. So this also helps in making the diagnosis if you can identify the scale. Like here in this patient, the skin is very dry, and over this dry skin these fish like scales are seen. Like if you see the surface of the fish, it appears very much like this. So this fish like scales are feature of ichthyosis. So if you find fish like scales, you can very easily comment that probably this is a patient suffering from ichthyosis. So you can identify the scales and you can identify or diagnose that condition. Similarly, colorate scales are seen in pityriasis rosea. So later on we will be discussing these conditions, pityriasis rosea, ichthyosis. There again we will be discussing this, but here colorate of scales is seen. Colorate like collar like scales at the periphery. So when you see the scales in pityriasis rosea, you will find the scales are present at the periphery of the lesion, and they are something like this, that is the peripheries are attached and the inner edges are free. So such scales which are present only at the periphery, something like this, are known as colorate of scales. Then in rheumatoid psoriasis, these heaped up scales are seen. In rheumatoid psoriasis, heaped up scales are seen. What happens that these scales are adherent. They are adherent to the skin. So they keep on accumulating upon each other. So one layer of scale, again another layer of scales accumulate over it, then again one layer of scale accumulate over it. So all these scales, they do not shed off, instead they keep on accumulating. So such thick heaped up scales are seen in rheumatoid psoriasis. Like you can see in previous slides of psoriasis, you have seen scaling was there, but this was not so heaped up and so thick like this which is seen in rheumatoid psoriasis. Then this is a simple silvery white scaling which is seen in psoriasis. Again you can identify silvery white scaling and you can elicit a sign also, Auspit sign, which we will be discussing later in psoriasis. Then in cradle cap is a type of seborrheic dermatitis. It is seborrheic dermatitis seen in infants. So seborrheic dermatitis of infants is known as cradle cap. Why it is known as cradle cap? Cradle is used by infants, and cap, why? Because I already told you seborrheic areas. One prominent seborrheic area is scalp, where we wear cap. So this is known as cradle cap. That is the seborrheic dermatitis which is seen over scalp in infants. Okay, this presents with greasy scales. Why? Because seborrheic dermatitis, sebaceous glands are being involved, and sebaceous glands secrete sebum. So the scales are greasy. If you try to feel them, they will be very greasy. So such greasy scales are seen over scalp, and they might also become very thick. So these are what? These are the greasy scales of cradle cap. Okay, so if you find greasy scales, probably the patient is having seborrheic dermatitis, and this is very commonly seen in infants, and gradually they subside with age. Then also you need to identify the pattern in the arrangement of the lesion. Pattern in the arrangement. Like here you can see this is a patient suffering from herpes zoster. Here the primary lesions are vesicles. As you can see, these fluid filled lesions are present. These primary lesion is vesicles. So all these vesicles are present, but the arrangement is dermatomal along a particular nerve segment. So if the lesions are along a particular nerve segment, along a dermatome, then it is dermatomal arrangement, and dermatomal arrangement which are unilateral along a particular nerve segment is usually seen in herpes zoster. Okay, and the vesicles are also present which are also suggestive of herpes zoster. Okay, so in herpes zoster you will find these fluid filled lesions which are unilateral along a particular nerve segment. So this arrangement also helps us diagnose various conditions. Okay, like the lesions can be annular lesions. Annular means round or oval shaped. Okay, so if such lesions are present, few conditions generally present with annular lesion like granuloma annulare, they present with annular lesions only. So you can identify the lesions and then you can diagnose them easily. Like these are the annular lesions, they are oval or round in shape. Similarly, lichen stratus present with linear lesions. Okay, so like in lichen planus, if the lesions are linear, we call it linear lichen planus. Similarly, in lichen stratus, the lesions are linear. So if the lesions are linear, then it is suggestive of the conditions which present with linear lesions like lichen stratus. Similarly, cutaneous larva migrans, here there are serpentinous lesions. So this larva is present beneath the skin and it is leading to this serpentinous lesion. Okay, serpentinous, like a serpent, like a snake. Then arcuate and polycyclic lesions. Such lesions can be seen in urticaria. Arcuate or polycyclic. Arcuate means like a arc. So you can see this arc, or polycyclic, like multiple cyclic margins are there. Cyclic. Okay. So such arcuate or polycyclic lesions might be present in urticaria. Then distribution of the lesion is also important, and you should look for the distribution of the lesion. Like if there are few conditions which only present over palm and sole, there are few conditions which only present over flexural areas or few over extensors areas. So the distribution of the lesion is also very important. Like palmoplantar psoriasis. So palmoplantar name itself is suggestive palm and sole. So if the psoriatic lesions are present only over palm and sole, that is palmoplantar psoriasis. So you need to examine the palm and sole in that patient. Okay, so acral distribution will be seen. Acral, that is hand and feet, will be involved. Like you can see this erythematous scaly lesions are present over palm and sole in a patient of palmoplantar psoriasis. Similarly, sometimes we use this term herpetiform and zosteriform. Herpetiform means grouped together, like the herpes lesions. If you see the lesions of herpes labialis, herpes genitalis or herpes zoster, they are grouped together. So you will find these clustered fluid filled vesicles which are grouped together in herpes. So since all of them are grouped together, we call them herpetiform. If they are along a particular segment, we call it zosteriform. That is, like in herpes zoster, they are unilateral along a particular nerve segment or dermatome. So in herpes zoster, it is made up of two terms, herpes and zoster. So herpetiform means grouped together. So you can see these vesicles, they are grouped together. And zosteriform means zoster, that is along a particular nerve segment or a dermatome. Okay, so this helps you diagnose these conditions. Similarly, intertriginous sites are those sites which are the flexural sites. Okay, so what are intertriginous areas? Like web spaces, axilla, groin, intergluteal folds. So all the skin folds are known as intertriginous areas. Okay, so what are intertriginous areas? Skin folds. So there are few conditions which only involve skin folds. Like one condition is Halle-Halle disease, where skin folds are involved. So if the lesions are present over skin folds, you need to think about that condition. Like Halle-Halle disease, it involves axilla, groin, inframammary fold, intergluteal fold, genitocrural folds. So skin folds are intertriginous sites.